Dear students, we are starting the 9th lecture in the Church of Traumatology and Orthopedics. It is devoted to such a topic as bleeding and blood loss. So, what is the concept of bleeding? Bleeding is the outflow of blood from the lumen of a blood vessel due to its damage or in violation of the permeability of its wall. Bleeding can occur on the surface of our body or in the cavity or inside the tissue space of our body. Depending on the cause, 3 types of bleeding are studied. So, the first type is related to traumatology, that is, bleeding in case of mechanical damage or rupture of the vessel wall. Another type of bleeding is bleeding that occurs during erosion, that is, with the destruction, ulceration or necrosis of the vascular wall due to some pathological process. Well, an example may be a malignant formation that destroys the vessel wall or, for example, peptic ulcer disease, which can lead to gastrointestinal bleeding. One of the variants of erosion can be with this type of bleeding that occurred after the injury and as a result of which the vessel stopped, the vessel was blocked, but due to the infection that joined after the purulent inflammatory process in the wound, it arose. This will also be erosive bleeding, that is, that occurred against the background of an inflammatory process in the wound. Another type of bleeding is bleeding in violation of the permeability of the vascular wall at the microscopic level. Well, an example is, for example, such a hematological disease as thrombocytopenic purpura. According to the anatomical, say, subtext, bleeding is classified into 4 types. So, arterial bleeding is isolated. Blood flows out quickly, blood drains under pressure. Often the bleeding looks like a pulsating jet. The blood has a bright scarlet color. In this case, the rate of blood loss, which we will talk about next, is quite high. The volume of blood loss depends on the caliber of the vessel and the nature of the damage, but with all the desire, if sufficiently large vessels are damaged, very serious blood loss can occur within a few minutes, up to blood loss incompatible with life. Therefore, arterial bleeding in the aspect of danger to the health and life of the patient is extremely serious. The next type is venous bleeding. In this case, when a venous vessel is damaged, blood flows out slowly, blood flows evenly, in a continuous stream. The color of the blood is often darker, dark cherry, and the rate of blood loss is significantly lower than with arterial bleeding. With a large diameter of the damaged vein, for example, such major veins as jugular veins, as femoral veins, as iliac veins. This bleeding may be very serious, up to a fatal outcome. In the case of smaller caliber veins, of course, bleeding will lead to serious consequences in the form of acute post-hemorrhagic anemia, but such bleeding cannot lead to a situation of incompatible life. In most cases, if we have bleeding on the background of a healthy organism, then after some time, of course, blood pressure will decrease, the rate of blood loss will decrease, and this vessel will be blocked. Capillary bleeding is probably the least dangerous in terms of the patient's health and life. Well, in this case it is caused by damage to small capillaries, small arterioles, a vein. The entire root surface is covered with blood again after drying. And a simple example is a banal abrasion on the surface of our skin. Blood flows out of the wound slowly, drop by drop, and with normal clotting, bleeding stops on its own. Probably the most dangerous in terms of the clinic and leading to the greatest number of deaths is parenchymal bleeding, which occurs due to damage to internal parenchymal organs, such as the liver, spleen, kidneys, lungs. The risk in this case lies in the fact that the peculiarity of the anatomical structure of the organ is the presence of the organ stroma itself. That is, the vessels are fixed in the stroma, they do not fall off. As a result, thrombosis of these vessels is extremely difficult. In some organs, such as, say, the lungs, there is even a feature of blood clotting specifically for this organ. It has sharply reduced coagulability. Plus, all these organs are deep enough and the damage to these organs is clearly not noticeable. Clinically, in this case, one can only suspect the presence of bleeding, and confirmation can be obtained either with the help of instrumental, or even often with the help of surgical techniques only. In this case, the outcome itself often depends on let's say, our clinical alertness and timely referral of patients with parenchymal bleeding to specialists at the stage of providing qualified care, that is, to surgeons. In relation to the external environment, all bleeding is divided into two main types, external and internal. In cases where blood flows out of the wound into the external environment, they talk about external bleeding. Such bleeding is obvious, they are easily and quickly diagnosed. Therefore, in terms of first aid, they are quite, let's say, malleable, and this procedure can be carried out. Internal bleeding causes bleeding, in which blood enters the lumen of a hollow organ, tissue, or in the internal cavity of the body, and, as a result, internal obvious and internal hidden and bleeding are distinguished. Internal latent bleeding is exactly the same precomatous bleeding that we talked about on the last slide, when bleeding and outpouring of blood occurs inside the cavities. For example, if it is an abdominal cavity, it is a hemoperitoneuma, and such bleeding is extremely dangerous because its volume is very large. The next type of internal latent bleeding is a hemothorax. It is also quite a serious thing, in which hemorrhage occurs in the pleural cavity. Hemopericardium is an extremely dangerous thing, accompanied by a discharge from the heart there, and in this case it is bleeding into the pericardial cavity. Well, the least dangerous, but directly related to traumatology orthopedics, are hemorrhages, bleeding inside the joints, and a more or less serious volume can be detected only with hemorrhages of the knee joint, when 100 or 150 milliliters can enter the cavity. As a bleeding in itself, affecting society, the body is negligible volumes. At the same time, as a disease in itself, hemorrhoids are an unpleasant problem. To the question of internal obvious bleeding. This is bleeding in which bleeding occurs into the cavity of a hollow organ, provided that this organ is included in a system that opens outward. Then an example is gastrointestinal bleeding, in which we can either get black stools after some time, or if the bleeding is, say, gastric and extremely massive, we can get such a thing as vomiting coffee grounds. That is, all these conditions are extremely suspicious just at the stage of internal obvious bleeding, and when they are detected, the patient, of course, will be properly oriented and directed to the doctor. In this case, again, the surgeon. Classification of bleeding by time of occurrence. Bleeding can be primary and secondary. The occurrence of primary bleeding is directly related to damage to the vessel, well, in our case, during an injury. It manifests itself immediately or in the first hours after the damage. Secondary bleeding can be early and late. Secondary early bleeding usually occurs from a few hours to 4 to 5 days after injury, and there are two main causes of early secondary bleeding. Most often, this is either the slipping of the ligature of the vessel, and ligature is the method of final stopping of bleeding. If it is poorly applied, the ligature may slip off. Or it is the leaching of a blood clot from a vessel. Well, this may be due to the fact that a small amount of time has passed, the blood clot has not yet had time to organize, and the systemic blood pressure begins to rise, the blood flow accelerates. We are engaged in our recovery with the volume of lost blood and whether the spastic contraction of the vessel decreases, and in this case it can lead to the washing of a blood clot. This is also one of the causes of early secondary bleeding. In addition, secondary bleeding can be late, and they usually occur after 4 to 5 days from the moment of injury. Late and secondary bleeding refers, as I probably said at the beginning of the lecture, to corrosive bleeding due to the destruction of the vascular wall as a result of the development of an infectious process in the wound most often. In the course of bleeding are divided into acute and chronic. With acute bleeding, the outflow of blood occurs in a short period of time, and with chronic bleeding occurs gradually, in small portions. It is necessary for many days to have a slight periodic discharge of blood. An example of chronic bleeding is, for example, hemorrhoidal bleeding, which in most cases do not carry, as the bleeding itself, major serious consequences for the body, but they are present, they bother a person and are the cause, often of his seeking medical help. Diagnosis of bleeding. In the process of bleeding, our human body, of course, reacts to the situation that its contents flow out of the bloodstream. And he can react most often with general symptoms. The classic signs of bleeding are the pallor of the skin. Often the skin becomes important. This is an increase in heart rate, which is associated with a decrease in the central nervous system, that is, tachycardia, but also a decrease in blood pressure directly, that is, due to the loss of blood from the hydrodynamic system itself, which is called yes, the volume of circulating blood decreases, and in the final we have a decrease in blood pressure. The patient complains of weakness, dizziness, especially when lifting the head. When he freezes, he makes such complaints as darkness in his eyes, flies in front of his eyes, a feeling of lack of air, anxiety, nausea. The data of an objective examination, that is, a physical examination, what can we note? On examination, we see pale leather covers, cold sweat, excision. The patient is hypodynamic, he is in terms of higher nervous activity, often he can be inhibited, and up to serious variants of impaired consciousness. Tachycardia, thready pulse with a serious amount of blood loss, and that is, with serious bleeding, decreased blood pressure, shortness of breath, decreased diuresis. Probably the main points that can be found during the examination of the patient. Instrumental, that is, laboratory indicators. Studies of laboratory data on bleeding are important due to the need to diagnose and determine the volume of blood loss, as well as to monitor the dynamics of the patient's condition, the dynamics of his condition against the background of the effectiveness of our, say, treatment to restore the volume of circulating blood. That is, what can we offer here in this case? Estimate the number of red blood cells, that is, the norm, if you remember 4-5 by 10, the 12th per liter. Evaluate the hemoglobin content. The norm has sexual characteristics, if you remember, in women it is most often lower, in men it is higher, but the fluctuation of normal indicators is in the range of 125 to 160 grams per liter. Hematocrit is the ratio of the volume of shaped elements to the volume of whole blood, and normally this indicator is 44 to 47%. The specific gravity of blood was determined long enough before. Now this indicator is practically not used, but in practical medicine, after all, as such, the term has been preserved and normally it equaled 1057, 1060 units. I evaluate the laboratory indicator directly with bleeding. It is definitely worth saying the following. If we take blood for analysis directly here in the immediate vicinity of the time from the moment of bleeding, often we will not find any progress in the laboratory indicators of red blood, because with all our desire we take just the same blood that was in the bloodstream before. That is, if some time has passed from the moment of bleeding, even if, well, a little, within half an hour or an hour, we can already count on our body starting to compensate for blood loss. We can count on the fact that this very compensation begins to turn on, and it is primarily the release of the liquid fraction from the depot. And here we will just meet with the very phenomenon in which we have few cellular elements left, and the liquid fraction has somehow been replenished. And we will see a decrease in the concentration of red blood cells and a decrease in the concentration of hemoglobin, well, of course, a decrease in the ratio of shaped elements to the volume of whole blood, that is, a decrease in hematocrit. That is, here you should be aware and understand that the time factor also plays a fairly important role here. Blood loss. Repeatedly at the beginning of today's lecture, we spoke and pronounced this term. That is, it is a condition of the body that occurs immediately after bleeding, that is, as a result of this very bleeding and characterized by a number of adaptive and pathological reactions in our body. Blood loss is the most common symptom in acute injuries of the main blood vessels, especially in wounds of such large vessels as the subclavian, iliac, slow, and popliteal arteries. That is, in this case, blood loss is very often fatal with such large, damage to such large vessels. As a result of intense or prolonged bleeding, the blood develops directly. Please note that this table shows the classification of blood loss by Bryusov. Yes, that is, by the type of blood loss can be traumatic. I think it's understandable. As a result of wounds, this is one traumatic blood loss, or as a result of our therapeutic meningitis, that is, surgical traumatic blood loss. Blood loss may be pathological due to the disease of any pathological process that leads to vascular damage. We have already listed this condition when we talked about erosive bleeding. And there is artificial blood loss. This is an exfusion due to, say, donation, when there is a blood draw, or, oddly enough, such a method as therapeutic bloodletting has not yet lost its relevance, for example. Of course, now this method is practically not used, and the maximum where it can be found is in hematological diseases. According to the speed of development of blood loss is divided into acute, and in this case we lose more than 7% of the central nervous system in an hour. On the acute side, this is 5 to 7% of the central committee per hour. From the central committee is the volume of circulating blood, and on average, if you and I consider an average, say, a human body somewhere weighing 75 kilograms, then they usually take into account the average value of the central committee of 5 liters. That is, 5 dashes of 7% of the central committee is about 250, that is, we have 5% of the central committee. Let's figure it out again, that is, 10% is 500 for you and me, so it's 250 dashes somewhere 400 milliliters per hour if there is blood loss. In this case, we speak under acute blood loss. Well, chronic blood loss is less than 5% of the cc in an hour. By the volume of blood spilled. Blood loss is divided into small, it is 0.5%-10%, that is, up to 0.5. Sometimes in this case they talk about physiological blood loss, because in some situations or with a healthy donation, this essentially does not affect our body in any way. That is, blood loss up to 0.5 liters is compensated without problems for us in almost any organism. Well, unless extremely weakened and sick people, in this case, even half a liter of blood loss will be considered as a serious problem. Blood loss is average 10-20% of the cc is 0.5-1 liter. Blood loss can be large, this is 20 to 40% of the central committee, this is 1-2 liters. Blood loss can be massive, it's 40-70, it's 2-3.5 liters, and often in this case, the moment of substitution therapy already with massive blood loss requires the use of ERMAS, and the variant of blood loss is fatal, when with more than 70% of blood loss in this case there is a moment of incompatible life and death, say, of the organism. According to the degree of hypovolemia and the possibility of shock. Blood loss can be light, it's 10 dashes of 20%, a shortage of globular volume of less than 30%, and most often there is no shock in this case. Blood loss can be moderate with a deficit of 20-30% in the central nervous system, about a deficit of 30-45% of the globular volume. Shock develops with prolonged hypovolemia, that is, if we do not replenish the lost volume of circulating blood for a long time, we may eventually get hemorrhagic or, as it is now customary to say, hypovolemic shock. Severe hypoemia, yes, is a deficit of 30 to 40%, and in this case we often have an inevitable and extremely severe shock. This is over 40% of the lost central committee. Shock often occurs in severe forms, and very often we have, say, a situation of terminal conditions in a patient. Here is a rather interesting classification of the American classification of blood loss. It is interesting because some indicators are not ephemeral here. Yes, that is, the percentage of the central nervous system, the percentage of the globular volume that you and I still need to calculate, if you remember this term from physiology, that is, to perform some laboratory tests. And plus, we have said that laboratory tests are still not fast enough for our blood to respond in this case, and the correct indicators will be. There are quite interesting and simple primitive physical tests that can be applied to a person and, in this case, approximately, of course, determine the amount of blood loss. Unlike us, their blood loss is divided into classes. Yes, that is, we have 4 classes of blood loss. Yes, depending on this, respectively, the first class is the lightest, the fourth is the heaviest. So, here's a first-class blood loss. How can it manifest itself? That is, the volume of blood loss in this case is about 15% of the cc. Orthostatic tachycardia, that is, the heart rate increases by 20 or more beats per minute when a person moves from a horizontal to a vertical position. A fairly simple sample, which is easy to check. The second class of blood loss is the volume of blood lost, that is, the volume of the central nervous system is 20–25%. What can we observe here? Orthostatic hypertension, that is, decrease in blood pressure when moving from a horizontal to a vertical position by 15 or more millimeters of mercury, provided that the patient's diuresis is preserved. That is, 2 such indicators and we are talking orthostatic hypertension. Naturally, initially it is assumed that we are dealing with a supposedly healthy person. That is, he was injured, as a result of the injury there was bleeding, but the body is healthy, does not have any diseases. But in our case, here is the first or second class of diseases associated with the cardiovascular system. The third class of blood loss, 30–40% of the lost cc, is arterial hypertension in the supine position and oliguria, when less than 400 milliliters of urine are excreted per day. Well, the fourth class, which is accompanied by a loss of more than 40%, in this case we have large serious disorders in the blood circulation of the brain, which lead to a violation of higher nervous activity, that is, a violation of the patient's consciousness and goals. Well, here, of course, the fourth grade is described quite primitively, but the situation of the first, second grade is very interesting. Methods for determining the volume of blood loss. Well, in this case, the thing is quite difficult. It is the situation itself with an accurate assessment of the volume of blood loss. Yes, that is, we have not exactly talked to you just now, based on certain different samples. If we have an operation with you and in this case the blood loss we have with you will be directly related to our impact. Of course, you can try to calculate here. Well, you can calculate it by the mass of the dressing material during the operation. Yes, by the direct amount of blood that spilled out during bleeding. It is possible to assume an empirical calculation option, although it is, of course, very much not accurate. Here, pay attention, here is the situation with averaged figures of blood loss in injuries of various variants. Yes, and in the same table, surgical blood loss is presented in, well, most classical operations. Again, classical operations, because nowadays minimally invasive techniques are often used to perform most of the operations, and in this case, of course, we have to talk more often about a smaller amount of blood loss. Laboratory methods for determining blood loss include the determination of hematocrit, determination of hemodon level, determination of the relative plane, density and viscosity of blood. Here in this table this case is presented. If you and I are talking and claiming that quite a serious time has passed since the bleeding occurred and our body should have already reacted in terms of a compensatory response. Here, evaluating, say, these laboratory indicators, we can already judge the degree of blood loss. The old indicator of the specific gravity of blood is also given here, but this is purely a tribute to history and, say, an opportunity to see how all this correlates and combines with the usual traditional methods of laboratory diagnostics, such as the assessment of hemoglobin concentration and the assessment of such an indicator as hematocrit. In addition, there is also a hardware method, the use of electrophysiological impedosimetry. A method based on the assessment of tissue resistance. Not the most accurate method, in most cases it is still experimental. Well, the variants of, say, laboratory experimental techniques include indicator methods, which, of course, can be used, tried in the clinic, but in most cases it is still most often an experiment. This is the use of dyes, electrolytes, radioisotopes. Well, how easy it is to explain. Let's say we inject a certain dose of radioisotopes into the bloodstream, it is diluted with us, it spreads throughout the body. After some time, we take the blood and assess how much it has been diluted, how much the radiation dose has decreased, or, if it has to do with dyes, how much the concentration of the dye in the extracted blood has decreased in this case, and by how much this case has been diluted, we can approximately judge the volume of circulating blood. A rather serious point in assessing, let's say, the understanding of blood loss is the term of the so-called hypovolemic or, as they often used to say, hemorrhagic shock. In practical medicine, in addition to the concept of blood loss, this term is used in parallel, hemorrhagic or hypovolemic shock. Here it is necessary to separate and very seriously separate one from the other. What is the concept of acute blood loss, in which there will also be very similar manifestations and a decrease in blood pressure or an increase in heart rate? And what is there in the concept of hemorrhagic shock? Here in this volume of today's lecture, let's analyze the understanding that there is, yes, a clinic of shock of the first degree, second, third. And here, taking into account, say, the classical old classification, I will give you the fourth degree of hemorrhagic shock, which is now most often called a little different, it is called a terminal state. But in the next lecture, when we will analyze traumatic shock, we will draw an analogy with hemorrhagic shock. But, looking ahead, I'll tell you one little thing. It's just that in the pathogenesis of shock development, you will need to pay attention to certain points. For the moments of violation of tissue respiration, for the moments of violation of biochemistry in tissues, and as a consequence for the moments of problems with microcirculatory flow. That is, the finale of all this will be the pathogenesis of the shock of the development of DIC syndrome. So this is the cardinal difference, that there is a concept of shock, and that there is a concept of just acute massive blood loss. With acute massive blood loss as such, the internal combustion engine does not develop, problems with the galloping of the shoulder blades in the tissues do not begin. There are no such serious problems with, let's say, with the passage of blood through the microcirculatory bed. And as a consequence of all this, there are no such big problems with hemodynamics in the final. We lose the volume of circulating blood in acute massive blood loss. The body tries to resist and compensate for this. Often, with our help, he does it well. In the case of shock, we still have a complex of serious pathological problems both at the intracellular, tissue level, and at the level of systems, especially systems such as the blood clotting system. So, what is a mild hemorrhagic shock? That is, most often the deficit in the central committee in this case is not a very large percentage, about 500-1,000 milliliters, that is, 10 to 20% of the lost blood. But against the background of an often weakened organism, we will talk about this again in the next lecture, against the background of some prerequisites, we can bring down the compensation system and lead to the development of pathological phenomena, as we have already said, with coagulation in the microcirculatory channel. So, 10 to 20%, which is insignificant, most often affects the condition of the wounded or injured. The skin of the mucous membrane is relatively pink or pale. The main indicators of hemodynamics are stable, but the pulse quickens to the figures of 100 beats per minute, with historical blood pressure decreases to the figure of 90, 100 beats of millimeters of mercury. That is, the Aldover shock index in this case is usually equal to 1. Hemorrhagic shock of moderate severity. The deficit in the Central Committee is already a more serious figure, 20-40%, that is, it is approximately 1-2 liters for the average person. The clinical picture of shock of moderate severity develops, that is, it is pallor of the skin, cyanosis of the lips, cyanosis under the nail beds, palms and feet are cold, the skin of the trunk is covered with large drops of cold sweat. The wounded man is restless, his pulse is 100 to 120 beats per minute, the level of systolic blood pressure drops to the figure of 85 to 75 millimeters of mercury. The kidneys produce a small amount of urine. With a decrease in blood pressure, filtration slows down, that is, it decreases, and we have the phenomenon of oliguria, which, remember, we talked about when we analyzed the American classification of blood loss and talked about blood loss of the third class. The third degree is severe hemorrhagic shock. The deficit of the Central Committee is extremely serious. 40-60% of the cc is 2-3 liters. Clinically, this is manifested by a drop in blood pressure to figures below 70 millimeters of mercury. The figure of 70 milliliters of mercury is the boundary between moderate and severe shock. And why is it so clearly stipulated that 70 millimeters of mercury at the level of our traditional atmospheric pressure is the limit for stopping filtration in the kidneys? The pulse quickens sufficiently large numbers of 120, 140 beats per minute or more. The skin acquires a sharp pallor with a grayish sciatic shade, covered with drops of cold sticky sweat. Pronounced cyanosis of the lips and under the nail beds. The creature is oppressed to the point of being stunned. Well, as I said before, the kidneys completely stop producing urine, oliguria occurs, an extremely severe form of shock. Sometimes it is called a shock of the fourth degree, sometimes they talk about terminal states. It is accompanied by a deficit and a cc of more than 60 milliliters. That is, if we take a purely hemorrhagic shock, yes, that is, we will have hyperemia of more than 3 liters in the volume of circulating blood. Clinically, the picture of the terminal state is determined, that is, up to the disappearance of the pulse in the peripheral arteries. The heart rate can be determined only on the highways, on the carotid and femoral arteries. Moreover, the purity is very high, yes, that is, at the moment of pre-agony, it is 140, 160 beats per minute. Blood pressure is often not determined by traditional methods, but by the method of short and the method of shortening. The state of consciousness deepens to a dispute, the skin is sharply pale, cold to the touch, moist lips under the nail bed are gray. Well, then, as you understand, after, say, the fourth degree of traumatic shock, we have a clinical death. So, in order to avoid this, it is still necessary to properly provide assistance to the victims. Assistance, for example, to victims of bleeding comes down to 3 main points. This is stopping bleeding, this is compensation for acute blood loss, and this is prevention of secondary bleeding. Options for stopping bleeding, that is, there is a temporary and final stop. A temporary stop of external bleeding is provided with first aid. Here on this slide, the types of this very temporary stop of bleeding are listed. Well, let's start with the simplest, with the elevated position of the limbs, and it should be said that is a separate type of stop. Yes, that is, a temporary stop of bleeding, well, probably the least relevant thing. Temporary elevated position of the limb. But as a moment of addition to other methods of stopping bleeding, this very simple method is very complementary and effective. The next option for temporarily stopping the bleeding is a pressure bandage. With the most frequent bleeding, that is, with venous, most often it is a temporary stop of bleeding in the form of a pressure bandage. It turns out to be final in the final. Yes, that is, the imposition of a pressure bandage in the area of a bleeding wound causes compression of blood vessels from the outside, stopping blood flow in these vessels and contributes to a fairly rapid intraluminal thrombosis. That is, a qualified application of a pressure bandage can even help with arterial bleeding. The technique of applying a pressure bandage on the next slide will be shown to you in the form of a video fragment. But in terms of comments, It should be said that first you should check whether it contains foreign objects, glass fragments, well, any foreign bodies. To free the place of injury from clothing, lift the injured limb above the level of the heart, yes, when the patient is lying down. After that, several layers of sterile gauze in the form of napkins are applied to the wound. We will discuss this with you at a lecture on wounds. And in the absence of, well, sterile gauze, you can just try to at least attach a clean cloth. A handkerchief, a piece of some kind of cotton cloth. Tightly press the edges of the wound, at the same time bringing them together. On top of the gauze, to strengthen compression, they usually put a pillow made of a dense lump of rolled bandage, fabric, perhaps even just a bag of cotton. The situation is greatly simplified if there are specialized means to provide first aid, in this case, the so-called individual dressing package. The veins and capillaries squeezed by the bandage are tamped down quickly enough, so this method of temporary stopping can sometimes turn out to be final in the end. If necessary, the limb can be tightly bandaged 5 to 8 centimeters below the wound. In this case, the venous vessels are squeezed throughout, which further contributes to the formation of a blood clot and, as a result, stops bleeding. Indications: any injuries, mainly of the limbs, accompanied by bleeding. Advantages of this technique: the most gentle, quite effective way to stop any bleeding. It should be said that a pressure bandage is probably 99% of all cases of first aid for bleeding. Disadvantages are also present. Not in all cases it will stop the bleeding. Let's say that it is extremely difficult to stop the injury of large main vessels, and if it is also an arterial vessel, then even more so. Tissue pressure can cause circulatory disorders in the peripheral parts of the limb. Of course, this situation is more typical for stopping bleeding with a tourniquet, and with a tight pressure bandage, this is also quite possible.
A pressure bandage is applied for low-intensity bleeding that occurs with damage to veins, capillaries, and shallow cuts. In order to apply a pressure bandage, we will need a sterile skein of bandage or napkins. This is the first layer that we put directly into the wound. It both tampons the wound and will increase the tension of the bandage. Then we take a sterile screw and begin to apply a pressure bandage with circular rounds. First, we will leave a small tail in order to fix the bandage later, and begin to bandage. With each round, the degree of our tension should increase not only due to the fact that we pull on the bandage, but also due to the fact that we can do such wrapping rounds, crossing the bandage, thereby increasing the tension on the sterile material. After the bandage has stopped being soaked in blood, we stop and fix the bandage. The criteria for the effectiveness of applying a pressure bandage are, firstly, stopping bleeding, secondly, there must be a pulse below the place of application and the limb should acquire a purple hue due to the fact that we stopped the venous blood flow.
So, the next method of temporarily stopping bleeding is the maximum flexion of the limb. I don't use the method often enough compared to everyone else, even those who will understand, but as a method in itself has the right to exist. Stopping the bleeding by maximum flexion is possible when the subclavian axillary artery is damaged by placing the hands as far back as possible and pressing them to the back. This is how the artery is squeezed between the clavicle and the first rib. Here pay attention to the attached illustrations. This is in the picture under the letter R unambiguously. In the next, when the arteries of the upper third of the thigh or inguinal region are injured, flexion in the hip joint. This is option B. Let me remind you again, here are the first options A and B are not always effective. The pressure in these arteries is very high, but this method, well, let's say, quite pessimistically, we can say, is not always effective. On under the letter B is a variant of stopping bleeding from under the knee artery. Here, in this case, such an impact will be more effective when some kind of rolled-up bandage is inserted into the popliteal fossa, and either matter and the knee joint is bent so tightly. The situation is exactly the same with figure D, where, say, wounds in the area of the elbow bend. In this case, you can also try to stop the blood loss. Using this method to stop bleeding from distal, that is, distant parts of the limb is possible, but again, I say, it is impractical. In these cases, applying a tourniquet is much more effective. This technique will be discussed in more detail here. So, indications for maximum limb flexion as a method of temporarily stopping bleeding. Stopping all types of bleeding and inguinal, under the knee vaccine areas. The second option is the first stage before applying other techniques. That is, as an option, well, let's say a temporary stop, it will be a temporary, but already a better stop. The advantage is the speed of application, the possibility of use in areas where the location of vessels is deep and difficult to access. Inguinal, subclavian area, popliteal axillary fossa. Another advantage is the possibility of using with a minimum of dressing material and a minimum of improvised means, in the absence of harnesses, in the absence of a first aid kit, and so on. What can be attributed to the disadvantages? Flexion of the end joint may be ineffective, I have already talked about this. Especially this option is ineffective with the letter A, with damage to subclavian vessels. Sometimes this method can be very painful and uncomfortable in terms of its long existence, as a temporary stop. The following method of temporary stopping is probably the most well-known among both doctors and ordinary people. But in most cases, no one, not even health workers, has ever used it in their lives. It is quite a rare phenomenon when it is required to apply a tourniquet, but it is necessary to know and be able to do it. So, applying a tourniquet is the most reliable and fast enough method. The tourniquet is applied by circular compression of the soft tissues of the limb together with the blood vessels and pressing their underlying bone. The application of a tourniquet is indicated only with severe arterial bleeding from the arteries of the extremities. In all other cases, it makes sense to recommend changing other methods. In our country, the most widespread elastic tourniquet with Varka, made of classic rubber. It is a rubber strip about 1.5 meters long. In our modern design, plastic buttons are fixed to the end of the strip, and at the other end there are holes at a certain distance. The overlay technique is quite simple. That is, in order to prevent infringement of the skin under the tourniquet, it is necessary to bandage some matter. Bandage, towel, or leave a piece of clothing. The limb is slightly lifted up, the tourniquet is brought, that is, the Narka rubber tourniquet is brought under the limb and stretched with 2 hands. Here, pay attention to this in our figure 1. Wrap around the limb several times without loosening the tension. Moreover, the first round of this, he is the most powerful, strong. Be sure to cross the ends so that one is layered on top of the other. This allows you not to stretch out in the future, not to untie the harness. After that, the tourniquet is wound one layer, one above the other, and the tourniquet rounds should lie next to each other so as not to infringe on the skin. The ends of the harness are fixed with these plastic buttons. The effectiveness of laying a tourniquet is evaluated before the bleeding stops. So, with a properly, effectively applied tourniquet, arterial bleeding stops, the limb turns pale, there is no pulsation of blood vessels below the applied tourniquet, it has stopped. Excessive tightening of the tourniquet can cause the reproduction of crushed tissue. Therefore, it is also not worth abusing physical efforts here. If the nerves are damaged, this can subsequently lead to a violation of nervation and to paralysis, cuts of this limb. A loosely tightened tourniquet, on the contrary, does not stop bleeding, it only creates venous stagnation and the limb does not turn pale, but acquires a bluish hue and the bleeding increases even more. The tourniquet should be applied in moderation and it is not recommended to cover it with anything. He should be conspicuous. After applying the tourniquet, immobilization of the limb should be carried out with the help of a splint. Due to the complete cessation of blood circulation in the limb when applying a hemostatic tourniquet, there is a direct threat of limb necrosis. Therefore, the tourniquet cannot be kept for a long time. Different sources of information, authors estimate this time differently. But the traditional information, which is taken from Vishnevsky's textbooks on military field surgery, which is based on the empirical experience of the Second World War, says that under physiological environmental conditions, that is, a temperature of 17 plus 25 degrees, that is, 17 on the lower limb, the tourniquet can be kept about, but no more than 2 hours. With, compression for more than 2 hours, the tissues will begin to die off. For the upper limb, the term is less. After an hour and a half, necrosis phenomena already begin. If possible, it is advisable to remove the tourniquet every hour. Yes, the first is to check whether the bleeding has stopped, whether the vessel has not been blocked, and at least for 15 minutes, even if the bleeding continues, then do with some other method. Either by finger pressing, which is most likely to be the most effective, or by bending the nuts as much as possible, and after 15 minutes the tourniquet must be returned back. And moreover, not to return for a long time. On average, it is quite small, that is, for half an hour or an hour, no more. Then we will have to repeat this procedure again, and with each such repetition, the chances of preserving the limb will still decrease. Therefore, the option of transporting the patient to the hospital surgically is extremely necessary here. When applying a tourniquet, it is necessary to specify the exact time so that in the future during evacuation it would be possible to examine, yes, these very 2 or 1.5 hours and clearly assess how much we have risks of limb necrosis.
An arterial tourniquet is used for massive bleeding, which occurs with open fractures or deep cuts, when stopping blood is impossible in any other way. To begin with, we will need the arterial tourniquet itself. Secondly, we choose the place where the tourniquet is applied. On the upper limb is the middle third of the shoulder, on the lower limb is the upper third of the thigh. And there is an exotic option of applying an arterial tourniquet to the carotid artery. It is then superimposed over the shoulder from the opposite side. The tourniquet cannot be applied to open skin, it is necessary to apply it to existing clothes or to lay any fabric. Also, the tourniquet must be applied correctly, we will show how. The first round is applied with maximum stretching to the place where the artery of interest to us passes. In this case, it is the brachial artery, so we put it on the middle third of the shoulder. We create the maximum tension and make an overlap in this place. Now I have one hand fixing the tourniquet itself, and with the other hand I can continue to apply subsequent rounds. We try to increase the tension with each round of the tourniquet in order to stop the bleeding as effectively as possible. Subsequent rounds are superimposed either on the same place, or with a slight offset by 1/3 or 2/3 of the width of the harness. This is done in order not to pinch the soft tissues located under the tourniquet. At the end of the overlay, we fix the harness with a special device, which is provided here, a plastic button and a hole. Accordingly, we simply snap it and the tourniquet remains on our arm. After that, it is necessary to fix the time of applying the tourniquet. In the warm season, this time is 60 minutes, in the cold season, 30 minutes. It is better to write it either on the tourniquet itself, or somewhere on the leather covers, or in extreme cases directly on the forehead of the victim. The tourniquet cannot be closed with a dressing material. It is necessary that it remains accessible for inspection and subsequently during transportation it is not lost, and information about it was transmitted on time and reliable. If the transportation took longer than 60 or 30 minutes, respectively, it is necessary to perform a sequence of actions. Perform finger pressing above the tourniquet, dissolve the tourniquet for 15 minutes. And after 15 minutes retighten the tourniquet slightly higher than it was applied in order to avoid damage to soft tissues. In the next 15 minutes later, repeat this procedure again, if necessary. What are the criteria for the correct application of a tourniquet? Firstly, it is a natural stop of bleeding from the injury. Secondly, it is the absence of a pulse below the place of application. Thirdly, it is a change in the color of the limb. It will be paler than the limb that we did not bandage. Well, it will also be cooler to the touch due to the fact that we have transferred arterial blood flow.
Quite often we have to face such a situation that there is no tourniquet at hand when providing first aid. There is an improvisation option in this case. That is, here at this wedding, the technique of applying an improvised tourniquet is presented, that is, a circular tug of the limbs, twisting auxiliary means. The accepted, that is, the so-called brittleness, the object used for twisting is freely tied at the right level, usually it is dense matter. A stick or a tablet is inserted into the formed loop. Here, pay attention to figure presented on the slide and twist until the bleeding stops completely. After that, this tablet, stick is fixed by the limbs. On the next slide, we will present in the form of a video fragment this technique of applying a twist. Applying a twist is a rather painful procedure, so it is necessary to put something under the twist, especially under the knot. That is, the fabric again must be bandaged, or some kind of towel or outerwear is preserved. All the errors, the dangers of cooling observed when applying the tourniquet and the scope of its application completely relate in the same way to the twist. I would like to emphasize once again that, according to the experience of vascular surgery, in 70–80% of cases of first aid, there is an unreasonable use of a tourniquet, a rather large figure. This happens in cases of damage to the reef. Yes, you do not need to apply a tourniquet, you need to try to stop the bleeding, let's say a pressure bandage. Yes, this is usually for bruised, multiplied wounds, pre-torn. To damage an artery, but we have a fairly high energy impact should be present, even if it is a lacerated wound, or it is a gunshot wound. The option of incised wounds can often lead to damage to the artery. In other cases, most often it is still venous bleeding. It must be remembered that hard rough objects such as wires, or ropes cannot be used for twisting. In these cases, there is a risk of reproduction of soft tissues, crushing them.
A twist is an alternative to an arterial tourniquet. It is used in cases of major bleeding that occurs with arterial bleeding, with a fracture of open limbs, with roughly deep cuts, when stopping bleeding is impossible in any other way. In the absence of an arterial tourniquet, a twist can be made. It is applied approximately according to the same principles and according to the same standards as the arterial tourniquet. Let's decide on the place where the twist is applied. If it is the upper limb, then it is the middle third of the shoulder. If it is the lower limb, then it is the upper third of the thigh. And an exotic variant of superimposing on the carotid artery over the shoulder of the opposite side. The twist cannot be applied to areas with exposed skin. There must be either clothes, or we are laying a bandage or some kind of fabric. You can make a twist from any improvised materials, from a piece of fabric, from a tie. We will make it from a bandage, an ordinary bandage. We cut off the fragment of the necessary length for us. We twist it a little and either immediately form a ring, or we slip it under the limb together with the overlay. We are already twisting here, tying the tail, making a ring out of fabric. Then we insert some oblong object there and begin, in fact, to twist. We twist it until it reaches the required pressure level. Actually, as long as it does not pass the artery, does not press it to the bone, we will see a stop of bleeding. After that, it will be necessary to fix this item with another round of bandage, so that our twist does not unwind during transportation. We wrap it tightly so that it all holds and fix it. Do not forget to write and specify the time of applying the twist, the same rules as for an arterial tourniquet. 60 minutes in warm time, 30 minutes in cold time. After this time, if they did not have time to deliver the victim to the hospital, it is necessary to perform an annular clamping above the place where the twist is applied, dissolve, untwist the twist for 15 minutes, wait and then tighten it again and fix it further with a bandage. Subsequently, it is necessary to impose a maximum of 15 minutes. If again during this time there was no delivery of the passenger to the hospital, it is necessary to do everything again. Now we will show you an alternative way of applying a twist when using just one skein of bandage and an oblong object. We choose the overlay location. In the case of the upper limb, this is the middle third of the shoulder, and we do several rounds in order to create a space between the twist and the skin itself. Regular circular tours. After that, we put an oblong object, which we will twist, and do a couple more rounds on top. Thus, we form a ring that will twist and cause pressure. Now we start twisting until the bleeding stops. And subsequently, with the same bandage, we continue to make the same circular rounds in order to fix the twist in our strained state. That's it, we fix the bandage, our twist is ready, it is fixed, and we write the time and transport the injured hospital.
One of the modern options for temporarily stopping bleeding is the use of tourniquet-type hemostatic tourniquets. Now and more these harnesses are on sale, and as imported. Here on the slide you are presented with an American-made harness of the Kate type. You see, there is such a marking here, and on the next slide we will have a video clip on the application of this harness and its comparison with our domestic harness, which has just started, went directly into production and on sale. So please look carefully. The video will be long enough for a few minutes, but it describes in great detail how modern harnesses look, how convenient, effective it is, and even the possibility of self-help is presented.
Today I would like to talk about ways to stop arterial bleeding in the field using special tourniquets or turnstiles. And today I have two of them on review. The first is the American Combat Application Turnstile CAT, a well-known model already. And the second is our response to sanctions, import substitution, a blood tourniquet stopping with a dial from MedPlant. Turnstiles for the review are provided by the Raid Gear Store. They differ in price exactly twice. The American is more expensive. Structurally, there is also a difference, but which one is better, now we will find out. Let's go! Let's start with the American Combatant Application Turnstile. It is delivered here in such a simple package in principle. The kit includes a very visual instruction, detailed, beautiful, with color pictures. Don't get confused how to apply it. The American turnstile is made of polymer materials. This is a stitched sling, plastic buckles, and a plastic lever for twisting and tightening the harness. I must say that it gives the impression of a very high-quality product. Plastic is thick everywhere, in principle it should not break. The only doubt is caused by the platform itself, on which the lever and a small double-slit buckle are located. This platform is quite thin and can be fragile, for example in the cold. The main double-slit buckle has teeth that exclude slipping of the harness tape itself, and it is made thick and reliable enough. There are no complaints here. The plastic lever itself, which is used to tighten the harness, looks just as reliable. There are special rings on it, which should exclude slippage when using it, for example, with wet hands or gloves, and it is fixed on such plastic half rings, or as they are sometimes called, horns. Eyelid hooks are sewn on the horns, and from above, such a loop is used for fixing, also with a strap, on which it is necessary to indicate the time of applying the tourniquet. Yes, and what is important, this turnstile is considered disposable. That is, this here is a strap with time, it is glued very firmly and it is disposable. You write the time on it once with a marker and don't use this turnstile anymore. although the materials from which it is made, in principle, in my opinion, allow it to be used repeatedly. Therefore, here you can already see for yourself. But according to the instructions, it is also disposable. An important advantage of this turnstile is its compactness. In a complex state, it takes up very little space. You can also fix the lever parallel to the axis of the main belt, and somewhere in the first aid kit it will not take up much space. If you urgently need to use the turnstile, it is very quickly transferred to the active position. That is, in this case, when you do not dissolve the loop, you can put it on a damaged limb, if a person can put this limb, as they say, into this loop. In this format, you can apply this turnstile to yourself with one hand. I'll show you how to do it now. In principle, this process does not cause any difficulties. A little more difficult if you need to dissolve the turnstile completely. This is done if a person has some serious injury, he cannot move the damaged limb, cannot push it into the loop, or this thrusting will be associated with even greater injury and increased bleeding. Then it is naturally easier to dissolve the entire tourniquet completely, push it into the double slit buckle and tighten it already on the limb. Here is an interesting constructive solution that is used by the Americans. The tape of the harness is sheathed with wooden panels, and moreover, these Velcro panels on the same side have both moss and hooks. That is, it can even be made by itself. Naturally, the grip density will not be as powerful as if the moss hooks were located separately, but it is very convenient to combine, connect, and fix this harness accordingly. That is, in this regard, it is very convenient. When the turnstile is already fixed on the limb, you tighten it through a 2-slit buckle and fix it on the second. Now you can start tightening the harness using the lever, rotating it clockwise or counterclockwise. The main criterion for a sufficient tourniquet is to stop bleeding in Iran. In our case, there is no wound, so we will evaluate the correctness of applying a tourniquet by the disappearance of the pulse on the radial artery, as well as by the fact that the limb should turn white. This, by the way, is an important point. Tourniquets are applied, as a rule, when it is necessary to stop arterial bleeding. That is, it is blood that moves through the arteries under high pressure, it is saturated with oxygen and, as a rule, it beats from the wound with a fountain. Such bleeding very quickly leads to blood loss and death of a person, therefore it must be urgently stopped quickly, for which harnesses and turnstiles are used. Arteries are vessels that have a muscle wall, and therefore it is much more difficult to transfer them than veins that do not have a muscle wall. Accordingly, an insufficiently tightened tourniquet will only transfer the veins, blood will flow through the arteries into the wounded limb, flow through the wound, and will not be able to return back, since the veins are squeezed and blood loss will only increase. Visually, you can see this because the limb will turn blue, and the bleeding will increase. Blueness of the limb is the accumulation of venous blood in it, it should not be. A limb that is devoid of arterial blood flow should become white, without blood. Accordingly, the absence of a pulse on the radial artery, and in general on all arteries below the place of application of the tourniquet, whiteness of the limb, these will be signs that the tourniquet is sufficiently well tightened. In our case, it is tightened well. Accordingly, when this happened, we fix the lever by one of the two horns and glue a strap on top, which indicates the time of applying the tourniquet. To dissolve the harness, you do not need to untwist the reverse lever. It is enough to simply unhook the velter and pull the tape along the double slit buckle. The American turnstile seems to me very convenient. Its main feature is that it can be used by a person on himself, having one injured limb, that is, it can be used with one hand. In general, the quality of manufacture, materials, functionality did not cause me any complaints. Everything is done normally. This tourniquet provides sufficient compression of the arteries, and the only thing that can scare away is its price. The turnstile that I have in my hands now, it cost $200-300 in the store, and this is certainly not a little, but life is probably more expensive. Convenience, ease of use, compactness, good manufacturing materials. In principle, I like this turnstile. What follows is our response to the sanctions. LCD-01 hemostatic tourniquet with a dial from Medplant Company. There is also an LCD-02, it is without a dial. This is where their differences end. The kit includes, in fact, the hemostatic tourniquet itself and the operating instructions. Here, of course, everything is more modest than the Americans, but there are also pictures and, in principle, everything is also clear. If the American turnstile actually fixes itself in a complex state due to these two-sided Velcro, where moss and hooks on each of the surfaces, then this version of ours is pulled together with such straps, which will naturally be lost. But 100% will be lost. Everything is classic with hooks on one side, moss on the other side, that is, this turnstile will not be fixed like this. After removing from the package, our turnstile, like the American one, is immediately ready for use. Create a loop, push the damaged limb into it, tighten the tourniquet. You can do this without someone else's help, independently operating with only one hand. Make sure that you have the tape already threaded into the first loop, in which case it will be quite convenient for you to use it even on your own, similar to the American version. If the wounded person cannot put the limb into the loop, then the turnstile can also be dissolved and cover the limb with it. We found the free end, threaded it into one plastic half ring, tightened it, fixed the Velcro and threaded it into the second half ring so that the whole system would not dissolve. And it is more convenient to do this than on the American version, because the Americans, as you remember, have a narrow double-slit buckle, and we have a wide plastic half ring, into which it is almost impossible to miss this free end, which, by the way, is marked like the Americans in red. The only plus, on the American double-slit buckle, there were teeth that prevented the sling from sliding back. We don't have that. The tightening element of the harness is represented by a plastic coil and a plastic lever that moves freely in this coil. The coil pulls out two slings, which reduce the overall length of the tape. Accordingly, the twisting goes along the axis of the tape itself, and not across it, like the Americans. Our constructive solution, it seems to me, is better than the American one. From what point of view? If in the American version you need these here orgasms, which the lever clings to and, let's say, the setting is not very fine, that is, every time you are forced to make a full turn, which significantly affects the tension force of the harness, then here the setting is more subtle. Accordingly, when the harness is tightened, the lever is fixed not by some horns that interfere and create some extra protrusions, but by the panel itself on which the lever is located. And of course there is also a damaged limb here, which will also provide fixation. To dissolve the harness or loosen the tension, it is enough to push the lever all the way down like this and it will shift one turn back and, accordingly, the tension of the harness will weaken. Is this a good constructive solution? Yes, excellent, in my opinion. In addition, the hemostatic tourniquet LCD01 with a dial has a dial on which you can specify the time when the tourniquet was applied. That is, there is a 12-hour marking, respectively, and you can indicate there that there was a tourniquet applied at 3:15, for example, or at 3:30. This ring is moving quite tightly and there are few options that it will accidentally move, but on the other hand they are there. On the other hand, these options with writing pieces of paper or writing time on the forehead, they are also associated with the risk that this inscription will be erased. Therefore, the option with a dial is not the worst, and what I don't like is that it sticks out like this to the side, and is mounted on the same flexible plastic on which the platform itself is located, and how stable and strong this plastic will be in the cold, how likely it is to break off this dial and lose valuable information about when the harness was installed is of course a big question. In general, there are by and large no questions about the manufacturing quality of this turnstile. It is also made of synthetic materials, good Velcro panels, stitched sling, thick enough plastic. The lever element itself and its tightening are made entirely of almost stiffening ribs and, in principle, should not break either. And the only thing that raises questions is this flexible panel itself, on which the lever attachment element is held. Plastic half rings, also very thick, are also unlikely to break. In general, the manufacturing quality is excellent, the design is good, so both of these turnstiles are suitable for stopping arterial bleeding in the field. Do not forget that turnstiles are imposed only strictly according to indications if bleeding threatens life. In summer, the time of applying the tourniquet should not exceed 1.5 to 2 hours, in winter, an hour. And here's a little cautionary tale. Once in class, my classmate at the military field surgery, he was asked how much you can put a turnstile in the summer. He said 2 hours. The teacher said excellent, Dmitri. And we put a tourniquet on him and clocked 2 hours. 40 minutes later, Dmitri cried out in pain, because a limb without blood first hurts, then it doesn't, and then it becomes unbearably scary that you will remain without this limb, although only 40 minutes have passed and it was summer. The tourniquet was removed from Dima and it hurt him for a very long time afterwards. Was Dima mistaken in his testimony? No, Dima said everything correctly. But don't forget, a tourniquet is a life-saving device, saving a life when blood loss threatens a person's life. And if there is no such need, you do not need to apply a tourniquet. This is one time. Yes, an important point, if you suddenly come across a person who, God forbid, has a tourniquet applied there for 3, 4, 5, 6, 7, 10 hours and this tourniquet has not been removed from him, do not first of all run and take it off. Necrosis phenomena have most likely already begun in the limb and the fate in this limb is its amputation. Amputation is performed just with the same tourniquet applied, and if you take it off, all these dead cells, all these necrosis phenomena will fly into the bloodstream into the systemic and a person may die from an infectious toxic shock. Do you need this? No, of course no one needs it. Most likely, this friend will already go for amputation. Also, when applying a tourniquet, remember, the tourniquet is always applied above the wound site, and as close to the wound as possible to reduce the amount of tissue that will remain without oxygen. And secondly, before applying a tourniquet to a limb, it is desirable to lift this limb so that the blood, under the influence of gravity from the limb of the glass gets into the systemic bloodstream, thereby reducing somehow the phenomenon of blood loss and only after that we already tighten the tourniquet. I remind you that the criteria for the correct application of the tourniquet are the disappearance of bleeding from the wound, the disappearance of the pulse on the arteries and the whiteness of the limb. I think you remember that. Also, do not forget, friends, do not fanatically tighten the tourniquet to an indecent state. You just smash the skin, the muscles under it, nerves and blood vessels. And even if a person survives blood loss, then it turns out that his hand is still not viable, because the nerves and blood vessels were simply crushed by a tourniquet. Also, do not apply a tourniquet to the skin, it is always applied either to clothes or to some kind of cloth, so as not to injure the skin and more gently squeeze the vessels. This also needs to be remembered. And finally, do not forget that the most effective, the most reliable and the most actually trouble-free to use is the Soviet version of the Esmarch harness made of rubber plastic tape. The only thing is that for its correct application, of course, you need a skill, you need to be able to do it quickly and correctly, but if you applied it quickly and correctly, then it is the least traumatic and most effective.
On the previous slides, we said that applying a tourniquet is a very effective technique, but at the same time quite often, which carries some negative side. The disadvantage of applying a tourniquet. There are quite a lot of them. The first is that the use of a tourniquet leads to complete exsanguination of the distal, that is, the peripheral part of the limb due to compression not only of damaged vessels, but also of all absolutely vessels feeding this limb, which for more than 2 hours can lead to necrotic phenomena, that is, to tissue necrosis. Nerve trunks are squeezed, which is the cause of various post-traumatic neurological complications, followed by prolonged pain syndrome, with impaired functions of walking, standing, and upper limb functions, that is, mechanical compression of the main nerves. Then in the future it can be very bad for us to respond. The cessation of blood circulation in the limb reduces the resistance of tissues to infection, reduces their regenerative abilities. The use of a tourniquet can, say, reduce the resistance of the tissue to infections, as we have already said, and to their ability to heal. The next disadvantage of the tourniquet is that the use of the tourniquet can cause severe angiospasm, lead to thrombosis in the future, say, in other parts of the limbs. The restoration of blood circulation after the application of the tourniquet contributes to the development of the so-called, possibly the development of turnstile shock. If we held the tourniquet for a very long time, the products of, say, decay, cell death accumulated in the tissues. Acidic products accumulated in the tissues due to the fact that there was an inefficient process of obtaining energy, and after the resumption of blood flow, these products can rush the whole body, which can lead to shock, pressure drop and acute renal failure. And from here there is a clear recommendation: if the tourniquet has been lying for a long time, then do not remove it yourself. In this case, it's just a long time. That means more than 2 hours, significantly more than 2 hours. Restoration of blood circulation, that is, the use of a tourniquet is impossible on the trunk. It is limited by anatomical features, so the tourniquet is only applicable to the extremities. Mistakes when applying a tourniquet and using it without indications. We talked about this on the last slide. It is often used for venous bleeding. Of course, attachment bleeding is just ridiculous. The next mistake is superimposing on a naked body. In this case, there is a risk of mechanical damage to the skin with its necrosis in the pressure zone. The application of his tourniquet is far enough from the wound. As you understand, the application of a tourniquet involves exsanguination of the body, so the more tissue it still receives in its normal existence, say, nutrition, the better the healing of the wound itself, and the existence of the limb in general, will be later. Excessive weak or on the contrary excessively tight tightening of the tourniquet. This has also already been described. Poor fastening of the ends of the harness. Often, during transportation, it is not possible to constantly monitor the patient, and it may happen that in the process of not sparing transportation, the tourniquet may dissolve. It's very dangerous. The absence of an accompanying note with a time record, whether in the form of a paper carrier, or information written on the human body about the time when the tourniquet was applied. And as a consequence, the following error may come out from here: that the tourniquet can be more than 2 hours, and there is a great risk in this. Well, closing the tourniquet with a bandage or clothes is also unacceptable. I'll explain the reason now. In the process of mass admission of the wounded, especially the wounded, who cannot loudly testify that they have a tourniquet and its duration is fixed in time, it may happen that the tourniquet may remain for a long time. It simply will not be noticed. It should be noted that even to Saxenta that I have already said that very often a tourniquet is unreasonably applied. A tourniquet is a double-edged thing. It can definitely be beneficial, but at the same time it can cause those large amounts of blessings that were described on this slide. Another very important method of stopping bleeding is the method of finger pressing of the arteries. As such, as an independently existing method, it is, well, probably not much used, but we will understand this further when we talk about their disadvantage. But as one of the stages of temporary stopping of bleeding, this is a very successful and very convenient technique. Usually, this method is used to stop bleeding. That is, while it is happening, well, at least even the situation, give me a first aid kit, take out a tourniquet from there, now we will apply it. For this period, the person who performs the functions, that is, rescuers, that is, the first one, he quickly tries to press the artery, yes, thereby reducing blood loss in the wounded. And this method, as already described on the previous slides, is very often used when we keep a tourniquet on the body for a very long time and we temporarily need to remove it. This method is used to temporarily stop bleeding on the extremities, on the neck, on the head, that is, where it is not possible to apply a pressure bandage, but it is still possible on the head, but not on the neck. Yes, or apply a tourniquet. Pressing is performed above the bleeding place, that is, the central one, where there is no large muscle mass, where the artery does not lie very deep and can be directly pressed down by the bone. The artery is pressed down with a finger, palm, sometimes with a fist. If this is a large artery, let's say femoral, then the pressure inside this artery is more than 1 atmosphere and often you just don't push your finger. The pressure points here are reflected on this slide. Yes, that is, you can stop the video, you can watch carefully, or all these lectures will be attached as illustrative material in PDF files directly to this educational cycle. Here, pay attention to the main points of pressing the artery. The temporal artery is pressed in the temporal region to the underlying bone of the skull. It is very careful with craniocerebral injuries, especially if it is assumed that there is a fracture here, that is, it is really clear that the skull is deformed. Along the maxillary artery, yes, it presses against the corner of the lower jaw. The same situation with the risks of injury to the bone apparatus of the jaw, yes, when we can allow displacement. Compression of the carotid artery. It is pressed against the cervical vertebrae, in particular to its transverse processes, somewhere at the level of the 6th cervical vertebra. This is just below the middle of the neck. So, the next artery that you can try to press is the subclavian artery. It is usually pressed against the first rib exactly in the supraclavicular fossa. Here pay attention to where it is located. Axillary artery. You can try to press it to the head of the humerus right here in the axillary fossa. the brachial artery directly to the humerus along the inner side of the biceps somewhere, that is, the biceps muscles, somewhere in the middle third of the shoulder segment itself. You can try to press the wrist artery in the area of the wrist joint. This is not a very large artery, yes, in the zone, that is, it is located on the side of the thumb from the radial side. Usually on this artery, if you remember, we measure the heart rate, that is, we try to estimate the pulse. It is already more difficult to press the femoral artery and the pressure is very high. You can try to press the femoral artery below the inguinal fold on the thigh. Yes, in this case, the pressure is usually carried out with a fist. You can try to press the popliteal artery in the popliteal fossa. Well, the artery of the back of the foot is usually tried to press the underlying bones between the first and second and third, fourth fingers, where they are large enough, that is, they bend the back surface of the foot in an arc and can bleed. So the indications for finger pressing of the artery, well, that is, the first steps to stop, as I have already said, bleeding most often begin with finger pressing. And this method is a precursor to the use of other techniques. The advantage is speed. You can do it instantly without having any first aid kits there, nothing. The possibility of use in anatomically complex areas, I have already said, the head, neck, axillary, subclavian fossa, groin area. This is the most gentle method of stopping bleeding. But, unfortunately, this method has many disadvantages. With pollen pressing, the vessels are squeezed by the nerve trunks located nearby and this is very sensitive. You can put a lot of pressure on the sandbox, it's also very painful. Prolonged stopping of bleeding by this method is impossible due to the rapid fatigue of the hands of the rescuer himself. This is probably one of his main drawbacks. Using this method, the creature reduces the intensity of bleeding, but most often it cannot completely stop the blood flow. Yes, and the blood flow goes through the collaterals, that is, through other vessels. Of course, this is good on the one hand, on the other hand, retrograde it may still be accompanied by bleeding from the wound. Due to the anatomical features of the location of the carotid, subclavian, axillary, popliteal arteries of a complex nature, their damage can often be completely ineffective. It is very difficult to find these arteries to press them. A separate variant of finger pressing can be directly clamping the vessels in the wound. That is, if the rescuer usually has personal protective equipment, that is, he is wearing sterile gloves, yes, if we visualize the vessel in the wound well, we can try to press it directly with a finger. After something, again, as a temporary measure, this is reflected here in the figure. When the veins are wounded, you can also use pollen pressing, which is performed distally, that is, closer to the periphery of the wound directly on the skin. Subcutaneous veins are often visible, you can try to press them. The next aspect of helping with bleeding and with the development of blood loss is compensation for acute blood loss. Here, please note, this slide shows the scheme of substitution infusion-transfusion therapy for bleeding by Brussel. The scheme is taken from a fairly age-old textbook, but with all the desire it is very concise and understandable. There is a division at the level of blood replacement and it is all clearly related to the volume of blood loss as a percentage of the BCC. Yes? The total amount of replenishment, yes, as a percentage of the amount of blood loss. You will notice that, with all the desire, it is customary to perform a much larger volume than we assume the volume of blood loss. This has a reasonable explanation for the fact that with, let's say, our infusion therapy, quite some serious volume will quickly go into the tissues of these crystalloid solutions, that is, liquids. Or, if we have normal high-quality blood pressure, it will simply flow into our bladder, I'm sorry. Now the question is what and in what, let's say, percentages to replace the lost blood. You remember, we will go through and analyze the variant of, say, infusion media, which are divided into colloidal solutions and colloidal solutions. Yes, colloidal solutions in our case are banal saline, these are Ringer-Wach solutions, these are Dissol solutions, residential co. Colloidal solutions are a little more complicated. Here this scheme is presented here based on polyglycine. The modern colloidal volemic drug is still not polyglucine. This is hydroxytyl starch and its variations. And he has some different from polyglucine. In many cases, modern GECI are much more effective, better and of higher quality than polyglucine. But at one time polyglucine bound more liquids on itself and therefore the relationship of the cross colloids there needs to be adjusted here. Here in this case, in this table. Therefore, the number of colloids here is worth, if we use HEC, increasing in percentage ratio by about 150–200%. That is, look, we have a volume of blood loss of 10%, that is, half a liter. Yes, we have to return 1.5 liters. And most often either monotherapy with crystalloids is used, or a combination with artificial colloids, as we have already said, with polyglucine. That is, if we take polyglucine, we have 0.7, somewhere 70% when performing a crystalloid and 30% with a colloidal solution of polyglucine. If we still use G with U, then, probably, the relationship here should be a little different. This is about half-half from crystalloids, alkaloids. The next option, we take blood loss of 20%, that is, about 1 liter. We have to make up 200%, that is, we have to spill 2 liters. And the relationship 0.5 to 0.5 is colloids and crucoids in the case of ours with U, say, the use of polyglucine. Again, if we use HEC, then the ratio should be somewhere, well, in principle, a fairly reasonable ratio of 0.505, but you can add a little more starch hydroxy. Next, I think you will sort out this table yourself. Just note that the more severe the manifestation of blood loss, the more other drugs appear. In particular, we have albumin, as well as natural transfusion replacement drugs, that is, erythrocyte mass, plasma, and so on. On the issue of colloidal blood substitutes. That is, just now we were talking about the fact that there is a difference depending on the generations of colloidal volemics. This table allows us to see it very clearly. Let's say, when there were, say, the 60s of the last century, a gelatin-based solution was used. Gelatino and so on. In the following he was replaced by polyglycine. This is a dextran solution. There were analogues of polyglucine, but with all the desire it has been used for a very long time. Practically now it is still being used, it has a place to be, as a component against shock in deposits and so on. Although, somewhere from the turn of the century, somewhere from the 21st century, hydroxytyl starch began to be used very actively. Here his representative ones are indicated here. They come with different molecular weights of this polymer itself, which is presented there, and there are variants with, let's say, a small molecule. You see, we have a kilo of 200 kilodaltons. This is a reference to its analogues, and with a variant of the average molecular, say, polymer of this starch itself, this is about 450 kilos of Dalton stabazole, its analogy. Here is an approximate volumetric effect. Note that if gelati 0 could bind about 70% of water, that is, if we introduce, say, a liter of gelatinol, then another 700 milliliters of crucoid solution, that is, it could hold liquids in the bloodstream. The most powerful indicators of polyglucine here, that is, 140%, yes, that is, somewhere per liter of injected polyglucine, a liter of 400 crucoid solution can stay in the bloodstream for a long time. Well, the calculation for GECS is 1:1, that is, 100%. Duration of the therapeutic effect. Notice how much the GACs benefit, how long they can stay in the bloodstream without sweating in the tissue. Yes, and also the ability to penetrate the vascular wall. If the low molecular heterofortin is still able to somehow penetrate into the interconvex fluid, then the high molecular weight, yes, the same stabazole, practically does not penetrate, yes, through the vascular wall. A very important positive effect of hydroxide starches is the low allergenicity of drugs. See how often he gave himself an anaphylactic reaction in Gelati 0 and how often he gave polyblucan. This is 0.27% of all injections that led to the occurrence of undesirable anaphylactic reactions. Therefore, these drugs were always administered with a biological sample, and if an emergency infusion was necessary, well, it was extremely inconvenient. Getty can be used, as well as cross-shaped solutions, without any preliminary biological test. An extremely low percentage of allergen, look, 0.006% only. It is also very important that, unlike polyglycine, hydroxyty starch does not affect kidney function. This unhealthy effect on the kidneys, the so-called dextra kidney, which developed with large volumes of transfused polyglycine, limited our ability to use large dose colloid solutions. Moreover, he limited it to a very serious dose, only 800 milliliters. The average daily dose was 800, well, sometimes they talked about 1,000 milliliters of polyglucine, which could be shed once, but it's still very bad. Starch hydroxyctyls are devoid of this disadvantage, they do not affect the renal membrane and they can be safely used in larger doses. Hydroxyethyl starch reduces the viscosity of the blood, that is, it is a drug that can perform an antiplatelet function. Depending, you see, the yellow even increased the viscosity of the blood, it worsened clotting. So, hydroxyty starch and polyglucine reduced it, but high molecular hydroxytyl starch, stabazole, yes, are commensurate in their rheological properties with the action of specialized choreological drugs, such as pentoxifylline or Printel, as he says. Moreover, the effect persists for a very long time, more than 30 hours. Well, and an increase in the half-life of organic kidney damage. Well, look, yes, that is, if our kidneys did not work well, then with all the desire, the pharmacological drug lingers in the body. That is, a high-quality HEC leaves the body quickly enough and leaves no consequences. Well, here it is presented, you see a bottle of 6% Refortin, a bottle of 6% stabazole. This is how modern colloidal volemic solutions look like with you and me. The program of infusion therapy using HECS, and here is a table with the use according to the recommendations of, say, our colleagues from overseas, that is, the American Association of Traumatologists, in my opinion, resuscitators. Please note that, depending on the class of blood loss, various options for the use of colloids are proposed, well, in this case, powders and crystalloid solutions. And in the case of us with serious problems, such as blood loss of the 3rd and 4th grade. Here we also begin to add transfusion media, yes, erythrocyte mass, freshly frozen plasma and even thrombomas. Well, that's it. Very peculiar packaging of drugs in their country. Yes, by the way, it sounds very interesting to our, let's say, Russian ear. If we have a traditional packaging of the drug, it is 200 and 400 milliliters in a bottle. Here, you see, they have 0.5, 0.75 and even 1.5 liters in, well, there's basically a plastic container. A few words should be said about such a class of blood substitutes as blood substitutes with a gas transmission function. For what to say? Well, of course, it's mostly a tribute to history, although these attempts to create an inexpensive and high-quality drug have not stopped yet and work is underway on this, well, in the pharmaceutical environment. Somewhere in the 70s of the last century, let's say, pharmacists thought about creating such a blood substitute that would not just increase the volume, would not just remain in the bloodstream, yes, creating an increase in the volume of circulating blood, but also carried oxygen, because after all, the main trouble of all blood substitutes except, well, probably, the traditional high-quality air mass is that we only replenish the volume and do not replenish the cellular elements, and with all our desire, if our blood only runs through the vessels and does not carry oxygen, well, we have a qualitative effect, that is, in terms of tissue respiration, we won't get it. Therefore, oxygen carriers were invented. These are environments of their own gas transmission function. Several countries were struggling with this. Well, Japan achieved active, let's say, results, but their non-drug was extremely toxic, very expensive and not very, well, difficult to use. As far as I remember, then the Americans retreated. They failed to create a drug, but in the Soviet Union, the drug was created. We called Perphteran. There was also another option, it was called Oxygent. A very peculiar mass. Right here, the picture does not allow you and me to even show what it looks like. Still, in those days, color photography was a little different. The drug is bright blue in color, so it was often called blue blood. It is still allowed for clinical use, it is called Perphther, but the drug is extremely expensive. Just extremely expensive, and therefore, oddly enough, for the state, for insurance medicine, in which we now live, human life is cheaper than the price of such drugs. Yes? The drug performs a microcirculatory oxygen transport function. It creates conditions for the rapid, complete release of oxygen from red blood cells and provides a protective membrane effect on them. Oddly enough, a small percentage of complications that he had, unlike the Japanese drug. At the moment, research is underway to create new drugs. And here is a diagram. Well, probably, after all, it is a tribute to the story of how it was possible to use Perphteran. The result of the research is the British drug Galendal. Its domestic counterpart is produced in our country. It is an oxygen carrier based on modified hemoglobin. It can be administered without determining the compatibility group, but this drug is made from human blood, so it is also extremely expensive in terms of our use. Currently, active research is underway on the creation of a similar drug from pig blood. Well, there were articles that the drug was about to be manufactured. By the way, these articles were somewhere about 5 years ago. To be honest, I don't see the result yet and the creation of an effective drug, say, with a gas transmission function, which would not be expensive and effective. The next stage of helping with bleeding is probably the final stage. This is the so-called prevention of secondary bleeding. And here what can be added to this section. This is either the final stop of bleeding by stopping its flow from the vessel, or, if we damage the main, not just stopping the bleeding, well, in the execution of the blood flow along this main. Let's look at what options for the prevention of secondary bleeding are possible in principle. The traditional moment is the dressing of the vessel in the wound, that is, the alloying of its ligature, that is, with a thread. And pay attention, this technique should be able to be performed by each of you, graduates of a medical university, regardless of whether you choose a therapeutic discipline, or you will generally be a functionary there, a doctor, let's say, a statistician somewhere in some medical organization. With all your desire, as a doctor, you should be able to perform doping and tie a vessel on a hemostatic clamp. The technique of execution is primitively simple, you know. Yes, we detect a bleeding vessel, yes, we clamp it with a hemostatic clamp, evaluate the effectiveness of blocking, say, bleeding from it. Then we wrap a sterile thread around the spout of the clamp, tie it efficiently and simply. We leave very small short tails, cut them off and that's it. Sometimes it is not possible to stop and catch the vessel qualitatively. Let's say the vessel is not, well, very mobile. Let's say a large subcutaneous vein. It is very poorly fixed under the skin, it is sometimes very difficult to catch it, it runs away. Therefore, sometimes the method of dressing is applied throughout. Yes, when, say, with the help of a ligature needle, remember the ligature surface of the Shana, yes, a thread is passed through soft tissues throughout the vessel of its projection and it is bandaged. Another variant of vascular ligation previously meant, there is such a term dressing with stitching. This is quite relevant in the case of arterial bleeding from a small artery. When we caught a small artery, we transferred it with a hemostatic clamp, but realizing that the bleeding from it was pulsating, assessing the risk of repeated bleeding in cases of slipping of the ligature, we do not just bind this vessel. We take the thread, fill the car holders. Everyone should also be able to do this, even a doctor of a therapeutic profile. We double pass the needle under its holder through the soft tissues crisscross. After that, we wrap the spout of the hemostatic clamp and tie it ligaturally as such. That is, in this case, we will not just bind the vessel and transfer it, but also fix this area to this point in soft tissues. In the case of a small damage to the vessel, basically it is a cut injury, that is, not the reproduction of a non-bruised wound in, say, a volume up to half the circumference of the vessel. We can apply a side seam to the vessel. The seam should be applied in such a way as not to reduce the lumen of the vessel. In all other cases, we will have to completely cross the damaged vessel, assess the integrity of the intima, that is, the inner shell of the vessel. Sometimes there is an option that you will have to do the so-called refreshing of the edges of the wound, that is, cut off a small area from each of the edges. If the edges of the vessel are multiplied, well, say, the edges of the vessel are multiplied. Sometimes this creates difficulties in order to bring the edges of the vessels closer together, and it is necessary to perform mobilization, that is, in some cases, to cut off the outgoing small branches from this vessel somewhere, bring them closer, and in this case we are talking about the main vessel, and perform a circular vascular suture. The method of applying patches, to a greater extent, is experimental techniques that clinically give a very dubious result, so this method is not particularly used. But the option of performing bypass surgery, in principle, is widely used. Bypass surgery can be direct or bypass. Bypass surgery is usually used when we have a wound, and most often it is secondary erosive bleeding later, suppurated wounds. And here it is necessary to overturn the shunt for a while around, say, the suppuration zone. Direct bypass surgery for fresh wounds, in the case when we have a large defect throughout the vessel and we cannot even bring the edges of the vessel edge closer to each other by mobilization. Then you have to use a shunt, and most often it is a Teflon prosthesis of the vessel, which is sewn directly into the vessel by infusion. End-to-end is the most convenient option. It creates the least amount of turbulence in the blood flow in the future, and as a result, there is less risk of thrombotic complications. The patient lives for some time with such an artificial vessel, taking anticoagulants. Because in this case, there is a high risk that blood clots form in this shunt. Previously, the autovein was used quite often for these purposes. Well, now we have come to the opinion that, with all the desire, yes, to perform prosthetics of a vessel of your own vein instead of an artery, but it's somehow not serious. Therefore, a Teflon prosthesis will be inserted, but somewhere within 2 months, the wall of this prosthesis will be lined with intimacy from the inside, and after some time, taking anticoagulants is not required, because from the inside we are. That is, there is an exhibition of life-correct fabric. Pay attention to this slide, even a video. For example, in a fragment we have a technique for treating a vascular suture. Wouldn't you say strongly all this is very clearly, well, as a small such brightening moment of our lecture can be viewed? Let me say goodbye to you. Yes, we will finish the lecture with you.